Hello to all my Latin American friends. I want to thank CLASS for the invitation and with Medifacos for being able to present the launch of Millenium XC, the first miniscleral multifocal lens for regular corneas. You may say, why put a miniscleral lens on a regular cornea? There are many patients who do not have a good tolerance with a gas-permeable lens when correcting their corneal astigmatisms, and patients with severe dry eyes where the soft lens is not giving the comfort that it needs throughout the use, despite the materials of high technologies that are used in these cases. Even many patients in whom we are doing ocular surface treatments with recovery of visual function and are presbyopic. So, until now, we could only correct far vision, and now we can focus on intermediate and near vision with very good results. Millenium XC is a miniscleral lens indicated for regular corneas, myopia, hyperopia, regular astigmatism, and presbyopia. This lens is designed with high technology, and we undress it to tell you about the parts that can be modified from this lens point by point. In the central part, where it is located in the optical zone, we have the possibility of requesting the opening of that optical zone according to the horizontal diameter of the visible iris, which is the data that they will have to give us at the time of ordering. Towards the fall of the limbus in the intermediate area of the cornea, if we want to bring the lens closer or further away, we can do it up to 200 microns. Even the limbal support area also allows us to move the lens closer or further away as soon as we have control over the oxygenation that it has to reach, and this area of stem cells to be able to reach the support area, which is divided into two sectors. One is the angle of support, which is designed to reach the sclera in a friendly manner and rest parallel to it with the edge itself, by being able to modify all the parts in the total diameter of this lens. Even by quadrant, we are facing a lens that still has no competition in the market. The technical specifications of this lens is that, particularly and speaking mainly from K, we make it in the optimum extra, which is a Contomac material of 125DK, having the possibility of carving in base curves that go from 7.76 to 8.65 in graduations from plus 35 to minus 35. Actually, a wide range that allows us to even correct patients with cataract surgery, and take into account that R's of the lens that patient does not have a close focus, therefore making a multifocal lens, making it a great result to prevent these patients who have had cataract surgery without intraocular lens, or have had to have it removed for some reason that may have in the same lens and a distant, intermediate, and near vision to work. The additions these lenses come in are up to plus 3.50 in steps of 0.25 by 0.25, and a toric front face can be carved. In cases of residual astigmatism, we can request from the factory a frontal toricity with cylinders that go up to -6 in steps of 0.25 in 0.25 on axes of 5 in 5. Therefore, the possibilities are as much or more than a toric white lens. All these lenses leave the factory by default with a surface plasma treatment to ensure excellent wetting without the need for artificial tears, being the touch against the eyelids very soft, even for cases of irregular tear film, and we can request HydraPEG contracting, although this is optional. What is the fitting philosophy of this lens? We are going to begin to give you step by step the way to adapt your patients with this lens in a simple manner, starting from the basis that, as it is a miniscleral lens, it encloses a reservoir of fluid that must completely cover the cornea, supporting the lens completely on the sclera. And you can see in the photo we have an absolutely covered cornea with absolutely no touch anywhere on its surface, and the limbus completely skipped, also with a scleral support without interruption of the blood vessels, which is fully supported in the 360 degrees of the lens. In any multifocal lens, the importance of centering is paramount. We must bear in mind that the proper alignment between the central axis of the lens and the visual axis of the patient is what is going to make use of the near optical zone that is in the middle, the intermediate, and far that are in the periphery. That is, use of binocular vision in simultaneous vision, giving the patient a natural vision without any type of reflections or ghosts. And there are three fundamental factors that are going to make this equation not so effective, and one is fundamentally that of centering the lens. Note that such a large lens obviously has a tendency to focus, but the irregularities of the sclera can cause this lens to have an off-center liquid and therefore shift off all its optic zones, thus not producing the effect of far, near and intermediate vision with the clarity that it's meant to have. Of course, another alternative in case the lens is perfectly supported and centered is that it is a pupil decentration. Later on, we will see what solution we have when the patient also has a nasopupillary difference, or there is an ectopic pupil difference that causes the central area of the lens to be displaced, so that the pupil is fully aligned with the optical axis of the lens. If we see in this photo, I have marked the pupil in the central part of the patient, although the lens is displaced towards the temporal side. In this right eye, there is a shadow in the nasal area and in the upper quadrant that indicates that I am not going to modify the limbal area, since, if you look at the fluorescein, in the lower part of this photo, it is marking that there is a decentration of the lens, which I must then correct, either by modifying the sector support of the meridian opposite the one that is touching, or in this case, we could make a periphery design with toric haptics, and that will then favor the centering of the lens, and possibly there is a pupillary alignment. In our test box, they have lenses with toric support, which are in group 2, to be able to place the lens and see if in that case we have already managed to correct the decency of the lens. In the case that it is the pupil that is displaced, as this is the case, we would then take into account the kappa angle. The value of the kappa angle in the angular distance between the visual axis and the pupillary axis. We are going to measure this in degrees and in millimeters to perfectly locate where I have to request the change of centering of the lens. And the central area is always in the pupillary part, and by means of laser lens marks, we will then be able to request the direction, the angle, and the number of the millimeters that we need to run the optical area. If we see in this photo, the Millenium XC lens has its laser marks in the area of the anterior face. You will only see this reflected in the lenses of the diagnostic box. Our test box has two groups of lenses. Group 1, marked as G1, are all single vision lenses in order to get the best distance vision. The central area of 3.5 millimeters is the one that will surround the pupil and the one that we will check if it is centered with respect to it. In the event that we want to contemplate a pupillary decentration, we are going to remove that lens and place an equal one, but from group 2, with toric haptics, so that the lens is centered and the alignment of the central area with the pupil is seen, as we have said previously. Markings will only be made on the trial lenses. The definitive lenses, unless you have a request for anterior toricity or toric periphery, which will come with the brands that our line of lenses are used to, will not have these markings that were used to design definitive. These circular lines are made with laser and are soft to the upper eyelid, nor will they accumulate an organic waste. And this will make it easier for the lens to be transparent, and we may also take visual acuity without problems. For this, I am going to explain a simplified adaptation in 6 steps. In this adaptation protocol, I recommend that you follow point by point to ensure, first of all, that we have not left any lens designs to chance, and therefore, in first, we are going to have to select and evaluate the trial lens firstly. Secondly, we are going to evaluate apical clearance. We already know that in the entire sclera lens, there should be no touches in the most prominent area of the cornea called the apex. Then the evaluation of the limbar clearance, which is essential that we have between 50 and 80 microns maximum in the limbar area to promote oxygen transmissibility. And if this is not fulfilled, because we have a cornea smaller than normal and the lens still in its minimum diameter tends for the vault to surround the limbus with a lot of clearance, we can request to lower that area and then also bring it closer. In the case that we have an excessive approach and we want to raise the limbus, we can request up to 200 microns of elevation in that area through customization. Fourth, let's look at scleral support. It is parallel to the sclera. Now let us then take into account the irregularities that it may present. And today we know with the scleral topography that we can have segments and sectors of the sclera that are irregular, and with this lens we can customize by quadrant and by toricity. Fifthly, we are going to evaluate the elevation of the edge itself, that there is no indentation and there is no interruption of blood vessels below the lens, or that the lens does not have excessive movement. If this was the case, keep in mind that when the lens moves, it will also move all the optical zones, and since it is a multifocal lens, the vision will not be good. Therefore, the lens must not have movement, for which we are going to be able to bring the edge closer. Finally, the overrefraction. These lenses, as I said, are all with distant powers. Thus, once we do the spherical and eventually cylindrical overrefraction, we will request the addition of fence. Very well. Step by step, I am going to explain how we are going to do this lens test. Selection and evaluation of the first trial lens. I will identify the K with keratometry and topography, and the flattest meridian, I am going to use a group 1 trial box lens parallel to this K. For example, if the cornea had a K, that is the flattest meridian, of 41.5 diopters, I will take the 41.5 diopter lens from my test box In the case that the keratometry is 41.25 and I do not have that lens in my test box, my suggestion is to choose the flatter immediate lens, for example 41. Once I have done this, and after 20 minutes of laying, I am going to do this my first clearance check. Ideally, my lens should initially have between 180 and 200 microns of clearance, so that once it settles, it remains as seen, precisely in the optical section of the photograph, close to 100 microns as ideal. I will then proceed to see the apex. Not only in the central area, but, for example, in the photo below, I am seeing that there is an area that is very close to the intermediate area of the cornea. If the central clearance is greater than 200 microns, I can request that the central zone be lowered and the intermediate zone raised, or my most effective suggestion, choose the next highest lens. Don't forget that we are working with regular corneas. Due to the carving of the optical zone of this lens, if I choose the immediate superior lens in number of diopters, that is a slightly more closed curvature, I will get out of the conflict zone and then I will evaluate the liberation of the limbo. See in this photo, my patient had a cornea greater than 12 millimeters, and this test box lens, that has a total diameter of 15.2, when it descends, was touching the sclerocorneal limbus. In this case, I am going to request a modification in the limbus, as I just explained, or you can use the resource of requesting to extend the total diameter of the lens. They can do it up to 15.5 millimeters. And bear in mind that in the case of lens diameter modification or the limbus modification, it is good that the horizontal diameter of the patient's visible iris can be attached as information. Then, I am going to evaluate the settlement in the scleral support. The patient in primary position must have a perfect centering in 360 degrees, and there should be no interruption of blood vessels in sight. And we can also observe that there is no pinguecula or pterygium. In the case of finding this absolutely white sclera, I think we have the adaptation that we are all looking for. In any case, we are going to observe in secondary gaze positions towards the nasal side, towards the temporal side, and the patient looking towards the bottom. We will then completely lift the eyelid and see that there is no tight blood vessels, no compression of the conjunctivital area, as it is important that there is free blood flow in the conjunctival vessels. This will of course guarantee a healthy adaptation in the number of hours of use for this patient. I take this opportunity to tell you of how many hours of use. In this test, I have patients with 16 hours of uninterrupted use with the sclera this white. Therefore, if the lens is perfectly aligned, this patient, through the lens and with such a low clearance, will receive the oxygenation he needs so that he can have a healthy use as long as he needs it, without the need to make a change of reservoir in the middle. Of course, if that is the adaptation criterion for each of you, you will evaluate it and give the patient suggestions that you consider appropriate. Keep in mind that there are 5 types of scleral profiles. At the junction of the limbus with the sclera, we can find the different types of profiles. This helps us understand why the lens angle of support is sometimes not aligned with the sclera, given the case that there is an imbalance between the standard angle with which the trial lens comes which is 54 degrees, in support with the sclera, I can request that this angle be varied up to 60 degrees at most and up to 50 degrees. In the least, that is to say, I can raise or close this angle to favor this alignment. This will make it possible to have a correct use of the intermediate zone to reach the edge itself. In the peripheral support, I can also find in this area of the intermediate support of the angle with a pinguecula or simply this compression of blood vessels that are seen in the horizontal meridian, indicating to me, even without having scleral topography, that this area is flatter than the vertical area. I will also check it by pouring fluorescein on the lens and seeing that there is an influx of fluorescein in the vertical meridian that will also bring detritus dragged, producing debris that will fog the lens on the inside, or it will cause that the reservoir becomes dirty with cells that come from the conjunctival area and the tear film itself. Do not forget that inside the lens we have completely transparent preservative-free saline solution, and any interruption of dirt that comes from the outside will stick to the lens on the inside, greasing, fogging or removing vision, and the patient will charge probably in 3 or 4 hours of use. In these cases, I am going to request a toricity in the part of the horizontal meridian, being possible in several levels, which are level 1, 2, 3, with level 1 being 150 microns, level 2 being 250, and level 3 being 350. If I asked it for this toricity, then once I have placed a uniform pressure in the 360 degrees of the sclera. And so, this possibility of customized peripheral adjustment will allow me to have several options. Not only the toricity in the horizontal meridian, but also the variation in the angle of scleral support, as I have explained. The clearance of edges, the test box has an edge that we call it standard, and can be ordered as a raised edge, a double raised, reduced, or double reduced. In the case of toric peripheries, as I told you, there are 3 positions. In the sectoral elevations, that is, if I divide the lens into 4 quadrants, in each of the hemispheres, I will be able to request punctually in a sector compromised at least 40 degrees, a lifting of that area to free myself from, for example, a pintle or a pterygium, or in the case of a hammered valve, I will be able to lift even in 3 positions up to 350 microns in the area that the valve occupies. The same in the control of the quadrants. If there is a small scar that makes the cornea in that sector irregular, even in the case of a regular cornea, due to the patient's pathology, I can request that there be an elevation of that quadrant to avoid touching the area that is marking me within the control of the patient. Therefore, this possibility, which we did not have before the Optimum XC monofocal design, today all the technology is put at the service of customization in the case of the Millenium XC multifocal lens. In the case of pupil decentration, I will normally have an area of 3.5 millimeters, and I can move the center of the lens from 0.5 to 1.5 millimeters in all axes, from 0 to 360 degrees. I show you here the asymmetry options. This patient had a significant pterygium and therefore, when supporting the lens, he completely deviated it towards the nasal side, making great pressure and of course shifting the entire lens, making visual acuity poor and giving patient the discomfort. The lens pivoted in all the other meridians because the part of the pinguecular lifted it a lot. And so we requested a lens with peripheral lifting, and I marked that sector according to which of the eye were a protractor. I would directly mark the between what angle and what angle I want the lift, and how many microns. In the case of the presence of this type of injury, it is not necessary for the patient to resort to surgery to remove it, but rather we will improve the total support of the lens in the affected region. The control by quadrant, if we take a look at what I just explained to you here, is completely marked. The lenses can be customized, and keep in mind that the control per quadrant can be not only in one sector, but it can be up to 2 different sectors of the lens. Nothing more than it will have to have at least a 40-degree difference between each other, because if it is not a whole sector, we are changing and the lens would behave falling towards the opposite side. The over-refraction is done on the lens fully centered. The power of the lens is determined, first in the spherical value, and then I suggest to do a keratometry above the surface of the lens, because then I am going to make sure that there is no residual flexion, astigmatism. And if you look at the keratometry, there is a difference of almost 1 diopter, and that will translate into residual astigmatism, which takes away the patient's vision. If that's the case, I have to make sure to remove this flex, which is usually due to poor lens support due to the toricity of the sclera. Keep in mind that if I ask for a toricity of level 1, which is 150 microns, I will correct a bending of up to 0.75 diopters. Therefore, if I have a greater flexion, I have to consider a greater lift in the horizontal axis for the toricity. It must also be taken into account that there is a rotation of the lens, and if I need one checked that the residual astigmatism is not due to flexion and I want to order a toric anterior face, the marks on the lens that are going to be positioned in the same way as the definitive lens is positioned. This is why it is important to order from the factory the lens with a spherical cylindrical graduation and the axis that it gives, and also the axis of the rotation in which the lens was located to compensate with the same rules as a toric soft lens. And we are going to add the number of degrees the lens was rotated when it is clockwise, and if it is rotated counterclockwise, we are going to request the subtraction of that amount of degrees, taking into account that in 5 minutes of rotation there are 30 degrees. Multifocal option. Millenium XC multifocal, then, is a wide-range lens with binocular simultaneous vision concept. The vision must always be taken in binocular form, that is to say, in a monocular form, I will take the distant vision. And once the total refractive power of far vision has been determined, when doing the over-refracting with the near vision test chart, I will always do it in a binocular way. And once this has been contemplated, we will then have a better image fusion, and we will take into account that the near vision is in the central part of the lens. Then I used the first lens from group 1, and if I had to modify the decentration, I will put the lens from group 2 to determine how many degrees and the orientation of the decentration is. To take the vision, I am going to reposition the lens of group 1. I take the over-refraction, I take the addition, I mark which is the dominant eye, whether it is the right or the left, and the preference for better distance vision, intermediate, near, in the case of the patient that had an activity where he decided on a preference, for example, in desk work, and the patient wanted there to be better intermediate and near vision than far. If you tell a patient that the preference, then we will try to advise them as to what is the best visual compensation for distance. See then, going back to the importance of centering, that in a lens that is displaced with respect to the pupil, they are going to mark how many minutes, how many degrees, and how many millimeters it has been decentered for. This produces an aberration in near vision and ghosting, which therefore, although I have been repetitive, the secret of the operation of the Millenium XC multifocal lens is the centering. Here you have it in a big way, where you can see each of the areas. When you have to indicate how much to center, you are going to take into account how many millimeters from the end of the central laser marking zone to where the pupil ends, and how many millimeters in the center and towards where, taking into account the marking of the ring of the angles, to which angle the lens has been decentered, in order to then be able to request the definitive positioning of the near zone on the lens carved for the patient. See, I made it drawn there so that they are not confused. So the over-refraction will carry these values. The addition value, the pupil diameter in normal condition, the dominant eye, which is right or left, the preference for better vision, and finalize the adaptation normally according to the introductions that are made for all scleral lenses. Medifacos is a Brazilian company that is located in Belo Horizonte, and you can access to know absolutely our entire line by entering our networks or by sending us an email so that we can send you the information, or directly on the page of www.medifacos.com to see the videos, new events, and everything related to this great laboratory. I want to thank them and you for the presence on the networks. Thank you very much.